This is a note for a renal consult. It contains 215 words. To figure out what it's worth, we need to determine the level of care by taking apart the history, the exam, and the medical decision-making, and plugging that information into this table, which shows the documentation requirements for outpatient consults. These encounters require 3 out of 3 qualifying key components. You can use either the 95 or the 97 guidelines. In this case, the 95 guidelines work out better for the doctor, so these are the ones we'll use. Starting with the history, this is the table we use to figure out what level of history has been documented. Here, first, we have a valid reason for the consult, and we've also documented the requesting physician. Next, looking at the HPI, we state the patient is a 52-year-old white male who presents with severe proteinuria discovered 3 weeks ago after a routine UA. Denies any associated symptoms such as hematuria, dysuria, or urinary hesitancy. Using the 95 guidelines, this is what's required for a brief versus an extended HPI. In this case, we've commented on the severity of the problem, the duration, the context in which it was discovered, and also asked about any associated signs or symptoms. This adds up to 4 HPI elements, which means this does qualify as an extended HPI using the 1995 guidelines. The next step is to check the PFSH. Looking at the PFSH, here we've commented on at least one item from the past medical, family, and social history. So we get credit for 3 out of 3 components of PFSH. The next step is to check the ROS. Looking at the review of systems, here we've documented the most clinically relevant systems and then used the shortcut all other systems reviewed and are negative. Both the 1995 and 1997 guidelines state that this is acceptable. Therefore, we get credit for a complete ROS. Putting it all together for the history, here we have an extended HPI, 3 out of 3 components of PFSH, and a complete ROS. This adds up to a comprehensive history, so now the first key component is known. The next step is to check the physical exam. Looking at the exam, and using the 1995 guidelines, we've commented on the constitutional system, the eyes, the ear, nose, mouth, and throat, listen to the lungs, listen to the heart and look for peripheral edema, did a brief GI exam, assessed the patient's gait and station, and also examined the skin. This adds up to 8 organ systems, which is exactly what you need for a comprehensive physical exam. So now the second key component is known. The last step is to calculate the medical decision-making. Looking at the medical decision-making, it's always a good idea to systematically take apart the assessment and plan using the medical decision-making point system. Starting with the problem points, here the nephrotic range proteinuria definitely counts as a new problem for which additional workup is planned. The hypertension would count as a new problem for which no workup is planned. And the anemia is also a new problem for which additional workup is described in the note. This adds up to a total of 11 problem points. The next step is to check the data points. Looking at the data points, here we get 1 point for reviewing and/or ordering labs. Next, this nephrologist rocked it old school by actually spinning down the sediment and looking at it. You get 2 points for that. Finally, a renal ultrasound is ordered. This gives us 1 other data point. This adds up to a total of 4 data points. The next step is to check the risk. Looking at the risk, the relevant part of the risk table is the high risk part. We have severe nephrotic range proteinuria. This definitely may imperil the kidney function at some point, so it counts as an acute or chronic illness or injury that may pose a threat to life or bodily function. So this is definitely a high-risk encounter. So we have 4 or more problem points, 4 data points, and high risk. Even though only 2 out of 3 dimensions are needed, in this case all 3 dimensions point toward high complexity medical decision-making. So now the last key component is known. Now that we know the key components, we can figure out what level of care has been documented. Here we have a comprehensive history, a comprehensive physical exam, and high complexity medical decision-making. Remember, all 3 key components are needed, so this adds up to the 99245 level of care, otherwise known as a level 5 outpatient consult. When you put it all together, here's how the final note looks. 3 out of 3 key components are needed. Here we have a comprehensive history, a comprehensive physical exam, and high complexity medical decision-making. So the 99245 level of care took us 215 words to construct and is worth $244, which works out to $1.13 per word, which is very efficient documentation. If you want to learn to take apart a note like this, consider signing up for one of our E&M coding curriculums. We offer several different subscription options to match any practice pattern. For E&M coding education for multiple doctors, let us build you an E&M compliance web portal, which offers verifiable and trackable E&M coding education for multiple doctors.